Good evening, everyone, and welcome back to the Lipid panel. My name is Dr. Guy Mintz, and I am the chairman of programming for the Lipid panel, working alongside Chloe Mativi from the National Lipid Association. The Lipid panel was conceived to be a lipid clinic as a conference for everyone. Some institutions do not have lipid centers, so it's our opportunity to share cases with colleagues and topics of interest to all of us. I ask everyone who's here tonight to email us and let us know any topics you would like to have discussed, if you'd like to be a participant, if you have an interesting case, and it's an opportunity for us to introduce young faculty and established faculty to present these cases and talk through various disease states. So it's my honor tonight to present our topic of lipodystrophy hidden in plain sight. And we have a great panel with us this evening. Our moderator is Dr. Sydney Bredefeld, who is attending physician at NYU Langone, diabetes and endocrine department, board certified endocrinologist and lipidologist. She's an assistant professor of medicine at NYU, and she served as co-investigator on NIH and American Heart Association funded studies. Um, our case presenter is Rachel Zielinski, who is currently a first-year fellow in endocrinology at NYU Long Island Grossman School of Medicine. One panelist this evening, we have Dr. Lindsay Fourman, who's an assistant professor of medicine and board certified endocrinologist at the Metabolism Unit at Massachusetts General Hospital. She leads a clinical research program geared toward elucidating mechanisms and treatment strategies for cardiometabolic disease. In her role as associate director of the MGH Lipid and Metabolism Associate Clinic, she's developed clinical research in rare genetic and acquired forms of disorders, including lipodystrophy. Our other panelist this evening is Dr. Abhimanyu Garg, who is the professor of internal medicine and chief of the Division of Nutrition and Metabolic Diseases at UT Southwestern. He's director of lipid services at Parkland Memorial Hospital and UT Southwestern Internal Medicine Subspecialty Clinic. He holds a distinguished chair in human nutrition research. He's also director of the metabolic diseases at the Center for Human Nutrition. It is my pleasure to present this illustrious panel to you this evening. And let me hand over the program to Cindy, who will take it from here.
Thank you for that introduction, Dr. Mintz. It's great to be here and part of this panel tonight. We have a good amount of content prepared, and we'll see how much we can get through. Please forward your questions through the chat, and we'll address them as they come. And with that, I will turn over to Dr. Zielinski to begin our case presentations.
Thanks, Dr. Bredefeld. I'll get started with the first of two cases I'll be presenting this evening. I'll start by introducing both of the cases, and then we'll discuss other diagnostic aspects of the cases later. Case 1. Patient is a 48-year-old female who presented to the endocrinology office for uncontrolled type 2 diabetes and progressive lipoatrophy of her limbs starting at age 10, with fat redistribution to the upper trunk, neck, and face. She was diagnosed with type 2 diabetes at age 14 and severe hypertriglyceridemia in childhood. She also had hepatic steatosis and hypertrophic cardiomyopathy with a pacemaker placed at age 38. Her medications include U300 insulin glargine, 80 units twice a day, insulin aspart, 40 units with meals, metformin, 2 grams daily, fenofibrate, 145 milligrams daily, icosapent ethyl, 4 grams daily, and rosuvastatin, 20 milligrams daily. Her family history is notable for a mother with type 2 diabetes, and little is known about the medical history of other family members. On physical exam, her vitals were normal, her BMI was 20, fullness was noted in the submental region and neck, as well as mild facial rounding. As seen in the picture to the right, there was central adiposity with increased abdominal girth and hepatomegaly. Her extremities were very thin with minimal subcutaneous fat and visible muscles and veins. There was no acanthosis nigricans seen or violaceous striae. The image to the left shows the patient's finger stick glucose data, It's notable for fasting and postprandial hyperglycemia with values into the high 300s, which correlates with a hemoglobin A1C of 10.4. Other labs included mild transaminitis, an elevated CRP, and leptin level of 2. Her lipid panel showed triglycerides of 867, HDL of 20, non-HDL cholesterol of 135, and lipoprotein little a of 40. Moving on to our second case, this patient is a 41-year-old female who sought care for type 2 diabetes and severe hypertriglyceridemia with recurrent pancreatitis. She was diagnosed with type 2 diabetes at age 30, hepatic steatosis at age 35, and had multiple episodes of severe hypertriglyceridemia with recurrent pancreatitis and eruptive xanthomas. One such episode required extensive ICU stay, including intubation, dialysis, and extracorporeal membrane oxygenation, or ECMO. She also had irregular menses and infertility. Her medications included insulin degludec 75 units daily, insulin aspart 45 units with meals, metformin 2 grams daily, and fenofibrate 145 milligrams daily. Family history was notable for a father with diabetes and dyslipidemia. The patient also reported that he had a body habitus with central adiposity and thin lower extremities, which is suspicious for lipodystrophy, but he did not have a formal diagnosis. Physical exam was notable for a BMI of 20, fullness in her neck and face without plethora, central and truncal obesity. As seen in the picture to the bottom right of your screen, her lower extremities had lipoatrophy, phlebomegaly, and prominent musculature. And then as you can see in the top right picture, her arms had diffuse eruptive xanthomas, which were also present on her knees and buttock regions. She did not have violaceous striae and did have mild acanthosis nigricans. Her continuous glucose monitor was notable for hyperglycemia, both postprandial and fasting, which correlated with an hemoglobin A1C of 8.5. Other labs included mildly elevated AST and leptin level of 3.4. Her lipid panel showed a total cholesterol of 373, triglycerides of 2,042, non-HDL cholesterol of 361, and a lipoprotein A that was normal.
Thank you. Very good. So thank you, Dr. Zielinski. I think that before we open the discussion to our panelists, we'll take our first polling question. And in summary here, we had 2 female patients, both in their 40s, both with a combination of uncontrolled diabetes, despite very high insulin requirements, over 200 units per day in one case, and almost 300 units per day in the other case. Both had severe hypertriglyceridemia, despite several lipid-lowering agents, and a history of pancreatitis, as well as hepatic steatosis. These clinical findings were present along with the exam findings of lower extremity lipoatrophy and prominent musculature. So which of the following do you think is the most likely diagnosis? A, Cushing's syndrome, B, polycystic ovarian syndrome, C, familial partial lipodystrophy, or D, common central obesity? Okay, very good. And with that, 88% chose C, which was familial partial lipodystrophy, which was our answer here. And at this point, I'll bring it back to our panelists, Dr. Fourman and Dr. Garg. Looking at our patient's presentation and their photos, what specific clinical and physical features immediately raise your suspicion for lipodystrophy as compared to other conditions, Cushing's syndrome, or even just routine general obesity with metabolic syndrome?
I can start. Yeah, so thanks for presenting that, Kate. Those 2 really interesting cases. For me, when I'm evaluating a patient, lipodystrophy, there's many, it's a constellation of different clinical symptoms. There's no single set of criteria, but it sort of boils down to 2 things. One is the presence of lipoatrophy, and the other is the presence of insulin resistance. And if both of those are present, then that really strongly suggests the diagnosis of lipodystrophy. So just to explain what each of those mean, lipoatrophy meaning that there is a lack of fat And that could be generalized involving the entire body, or it could be partial, affecting only certain areas of the body. And in both of these patients, they had a presentation where, particularly in the legs and also the arms, there was a lack of fat, but there might have been an increase of fat in other areas, such as the trunk. And so that's lipoatrophy, and it's isolated lack of fat. So muscles are intact. There's not like also a loss of muscle. And so that's why you really see those prominent muscles and veins. And then insulin resistance. So there's many possible features of insulin resistance, type 2 diabetes, high triglycerides, fatty liver disease, polycystic ovarian syndrome. Those are all different manifestations that you can see in any one patient. And if you're seeing that combination, it points towards the lipodystrophy diagnosis. Just to mention about Cushing's, I do think that is sometimes an important consideration when seeing a patient, because Cushing's can look very similar sometimes to lipodystrophy. You can have a lack of fat in the arms and legs, more central fat accumulation. Cushing's also increased fat around the face, which can happen also with certain forms of lipodystrophy. But really what distinguishes Cushing's, one is that there's also a lack of muscle in Cushing's. So there's kind of a atrophy of both muscle and fat in the limbs. There's also, tendency towards a lot of different constitutional and other types of symptoms like easy bruising, muscle weakness, subjective symptoms like fatigue and mood disturbances and things. The chronicity in these patients, they had this for many, many years. The first patient you presented was diagnosed with type 2 diabetes at 14 years old. And so a lot of times I think Cushing's it could be underdiagnosed and take a while to diagnose, but doesn't tend to take quite that long to diagnose. But in some of these patients where we are evaluating for lipodystrophy, we do assess for evidence of hypercortisolism. That's an important consideration, because you don't want to miss that diagnosis, because that would have a completely different diagnostic and treatment pathway compared to lipodystrophy. So it is something to tease out in certain patients where there could be overlap in the presentation.
So I'll add here, Lindsay, that as it suggests, familial partial lipodystrophy is a familial syndrome. Most of the patients have autosomal dominant inheritance. So if you go deep into the family history, you will find either one of the parents or other siblings or their children affected with it. The only thing is, most of the patients with familial partial lipodystrophy, during childhood, they have normal fat, but they start losing fat as they go through late childhood or during early puberty. That's what happens, at least in one genetic form of lipodystrophy. The onset of fat loss may be different in different subtypes of familial partial lipodystrophy, and it's an area of active investigation for us also. So, as Dr. Zielinski mentioned, the first patient didn't have any family history, but the second one at least reported her father had similar phenotype. And that is helpful sometime to suggest an autosomal dominant inheritance. However, there are rare types of familial partial lipodystrophy known now which have autosomal recessive inheritance. And in those patients, the parents may be normal, but there is a possibility that other siblings may be affected. So we have to consider both the syndrome, autosomal dominant and autosomal recessive inheritance, when we are dealing with familial partial lipodystrophy. And then um, now we have almost like 8 or 10 genes known for these disorders, but still almost 40–50% of these patients have no mutations in the known genes. They may either have what sometimes is called as type 1 familial partial lipodystrophy or polygenic inheritance.
Perfect. Thank you so much for that summary. I think we'll continue on with some of our slides. And as a summary that was already stated, I think I can just offer this one particular slide, that lipodystrophy can be summarized as a heterogeneous group of disorders where individuals experience a complete or a partial loss of subcutaneous fat from certain areas, while again often accumulating excess fat in other locations, including internal organs like the liver. Again, it can be genetic or acquired. It can affect localized regions or less commonly the entire body or generalized. It's associated with other diseases of metabolic dysregulation, including insulin resistance, hypertriglyceridemia, and hepatic steatosis. So I have next 3 slides addressing the pathophysiologic basis for lipodystrophy, and I would just invite our panelists to comment or to add to the discussion as I go along. To start, the primary defect of lipodystrophy is the loss of functional adipocytes and a decreased ability to store lipids. So this figure to the right depicts the differentiation of adipocytes starting from mesenchymal stem cells into pre-adipocytes, mature adipocytes, and ultimately apoptotic material. No mutations in various genes responsible for adipocyte development, function, and survival are implicated in the genetic forms of lipodystrophy, and several examples of these genes are bolded and shown to the right of the picture. And we can discuss more about some of these specific genes as we move along. This figure illustrates how the decreased ability of adipose tissue to properly differentiate, develop, and function will lead to limited subcutaneous tissue expandability and a decrease in the capacity of the adipose tissue to store lipids. So loss of the expandable subcutaneous adipose tissue means that incoming lipid cannot be safely stored. Free fatty acids will spill over, driving ectopic triglyceride accumulation in the liver, the muscle, and the pancreas. This creates a lipotoxic state. And it's this ectopic fat deposition that leads to hepatic steatosis, muscle insulin resistance, and diabetes. And last slide, in addition to the havoc that ectopic fat accumulation causes in lipodystrophy, a leptin deficiency is also implicated. Leptin is mainly secreted by adipose tissue. It circulates at levels that are proportional to the percentage of body fat mass. So due to the severe lack of adipose tissue, patients with lipodystrophy syndromes can have low or even absent levels of leptin. And as illustrated here, leptin has a broad-reaching influence, normally demonstrating robust effects to reduce energy intake, increase energy expenditure, and lipid utilization. So conversely, a leptin deficiency can lead to increased hunger, reduced energy expenditure, and lipid utilization. So I do have one polling question for us, and then maybe we could go back if there's any comments regarding those pathophysiologic slides. So to begin with our polling question, which pathophysiologic mechanism best explains the severe insulin resistance that's seen in lipodystrophy? A, autoimmune destruction of pancreatic beta cells leading to absolute insulin deficiency. B, excess glucose secretion from the pancreatic alpha cell. C, reduced adipose storage capacity causing ectopic lipid accumulation. D, low leptin levels reduce hypothalamic satiety signaling. Or E, both C and D. Great, so about 76% of you picked E, which is both C and D in terms of ectopic lipid accumulation and low leptin levels. Any comments from our panelists? Anything to add regarding our past few slides?
Yeah, I can chime in. So yeah, I think lipodystrophy is a very interesting disease because I think as a society, we're always so interested in talking about excess fat and obesity. And lipodystrophy really highlights that fat does serve a really important biologic purpose, and the lack of fat can be just as detrimental as excess fat. And fat, we see that it's a storage depot for excess energy. And when you don't have that storage depot available, you end up with ectopic fat accumulation in other tissues, which causes dysfunction of those tissues and insulin resistance. And we also see that fat is beyond just a storage depot. It has a lot of biological functions. And leptin is one of those functions, and one of the ones that we know, I think, too, that it makes leptin, and this is really important in energy regulation, body weight homeostasis, And when people with lipodystrophy lack leptin levels, it's sort of lack leptin, it sort of is always signaling to the body that they're sort of in this energy deficient state, that they're hungry, that they need to eat. And it also slows down metabolism and promotes insulin resistance, that the leptin levels are low. Yeah, people have realized that those two things, and I think we'll talk more about it later in this panel. But the fact that we know leptin does contribute to the pathogenesis, it also may play a role in treatment, and we'll talk about that a little bit later on.
So I'll just comment that not all patients with lipodystrophy have low leptin levels. So the patients with generalized lipodystrophies definitely have extremely low leptin levels and voracious appetite. And then when we talk about the two cases that Dr. Zielinski presented with familial partial lipodystrophy, there can be low leptin levels, they could be normal, and in some patients, depending upon how much body fat they have, the levels can even be higher. So certainly both the reduced storage capacity of adipose tissue and hypoleptinemia may play a role in causing insulin resistance, but it will depend upon the type of lipodystrophy that you are dealing with.
Thank you. And in our two cases, the leptin levels were at the low normal range of that particular assay. Okay, so we can move on. Dr. Zielinski will discuss the prevalence of various lipodystrophy syndromes.
Thank you. So the true prevalence of each of the four main types of lipodystrophy is unclear, as published data has been mixed. However, a recent analysis using whole genome sequencing data from a UK biobank and a genotype first approach identified a prevalence of 1 in 15,820 for monogenic lipodystrophy, highlighting their under-recognition and diagnosis in clinical practice. As we've already stated previously, lipodystrophy syndromes can be divided into genetic or acquired and generalized or partial. In clinical practice, we'll see familial partial lipodystrophy, or FPLD, so we'll spend the most time today talking about that form. The other three forms of lipodystrophy are more rare and typically diagnosed in childhood, so we'll only have one slide dedicated to each of the other three types.
Just to note that we're going to place an article regarding the prevalence of monogenic lipodystrophy in the chat, if anybody wanted.
The first category of lipodystrophy is congenital generalized lipodystrophy, or CGL. This is an autosomal recessive disorder diagnosed at birth or during the first year of life. About 300 cases have been reported in the medical literature. These children have characteristic clinical manifestations, as you can see in the first picture to the right, including whole body absence of adipose tissue, coarse and triangular facies, well-defined muscles, phlebomegaly, and distended abdomens related to hepatomegaly. And as you can see in both pictures to the right, umbilical prominence and hernias are frequently seen. As the patients grow, their facial features tend to accentuate, acquiring an acromegaloid appearance with enlarged hands and feet. Insulin resistance and hypertriglyceridemia are typically present. The next category is acquired generalized lipodystrophy, or AGL. The symptoms are phenotypically similar to CGL, except that it occurs in a previously healthy individual. The progressive adipose loss typically starts in childhood or adolescence and will affect the patient's face, limbs, buttocks, and abdomen. The two pictures above to your left depict the same patient before she developed AGL at age 3 and after she developed it at age 6. This disorder has also been linked to viral infections and autoimmune diseases such as lupus and dermatomyositis, and antibodies against adipocyte membrane antigens may be involved. In acquired partial lipodystrophy, there's a gradual loss of adipose tissue from the face and upper trunk with disproportionate accumulation in the rest of the body, including the hips and lower limbs. Because the increased subcutaneous fat deposits are in the lower extremities opposed to the ectopic organs, minimal or no metabolic complications exist compared to the other forms of lipodystrophy. This slide shows the three main types of familial partial lipodystrophy, or FPLD. The leftmost two images display Koberling syndrome, or FPLD type 1. You can see in the picture increased abdominal and trunk fat and fat sparing in the lower extremities. The center image shows a patient with FPLD type 2. Here you can see fat accumulation in the neck and face of the patient and fat sparing in the lower extremities, creating a more muscular appearance. Type 2 is due to an autosomal dominant mutation in the LMNA gene. And moving to the right, this is the third type of FPLD, where fat accumulates in the trunk and neck region, again with relative sparing in the extremities. Autosomal dominant mutations in PPAR gamma are responsible for type 3. All three of these subtypes are associated with lipoatrophy of the lower extremities and often severe insulin resistance and hypertriglyceridemia. This slide is a nice summary slide depicting the various forms of lipodystrophy we have just reviewed. The first patient on the left shows CGL with acromegaloid features. Moving to the right, the next figure shows FPLD type 2 with excessive fat accumulation in the neck and face areas. The next figure shows FPLD type 3 with extensive trunk obesity. Figure E demonstrates acquired partial lipodystrophy with excessive fat accumulation in the legs. And all the way to the right, this figure represents AGL, which occurs starting in childhood.
Yeah, and maybe before we go to the next slide, I would just go back to this one particular slide. And if we want to just discuss how in clinical practice, how this could easily be mistaken for obesity. Certainly in a fast clinical practice where often we're not undressing our patients or, they're wearing long pants, you can easily see how the lipoatrophy of the lower extremities is not identified. Has anyone had this experience in their clinical practice for our panelists?
Yeah, I think when you look at these pictures that you think, wow, how would of course I would notice something like this. It's such a pronounced phenotype, but I think in real practice, a lot of patients are not being undressed and examined in this type of way. And I would really emphasize that this should be done, especially in a patient that does have severe insulin resistance, especially if it's disproportionate to BMI, where you don't really have another good explanation for why they would have such severe insulin resistance. It's really important to really ask the patient to get in a gown and look, again, back to what I said at the beginning, like signs of lipoatrophy. All of these pictures look a little different in terms of the exact fat distribution. And I don't think it's so important, if you don't typically see this in your practice, to really, nail down the exact subtype of lipodystrophy. But what I do think you should realize is if you see lipoatrophy plus insulin resistance, that should sort of clue you in that lipodystrophy may be going on, and then, potentially reaching out or referring to someone that is specializing in lipodystrophy for further evaluation. And it can make a really big difference for patients because there's certain treatments that, would be targeted for patients with lipodystrophy.
So the other interesting point is that, as you can see, what Dr. Zielinski is showing here are three females.
Yes.
And it is easier to diagnose lipodystrophy in females, and most of our probands from families with familial partial lipodystrophy are females. But if it is autosomal dominant inheritance, there should be equal number of males there, except that even after my 35 years of experience, it is very hard to clinically diagnose lipodystrophy in affected males unless they are presenting with either diabetes, hypertriglyceridemia, hepatic steatosis, or acanthosis nigricans. And once you see a muscular person with these features, yes, you can start thinking about lipodystrophy. The UK Biobank data was very enlightening because they started with genotype first approach. So in clinical practice of all of us, we see more females with familial partial lipodystrophy. But in the UK Biobank data, interestingly, they were same number of males and females, which is expected if you start with genotype. The other point I would like to make for the UK Biobank data, which was just published very recently, is that when they looked at their electronic health records, none of these patients who had the genetic variant associated with lipodystrophy were clinically diagnosed with lipodystrophy by their physicians. So clearly, patients are not being examined well. Uh, and as you said, Dr. Foreman, if you are suspecting in a patient with diabetes or hypertriglyceridemia, you're suspecting insulin resistance, you must do a full physical examination and also maybe measurement of skin fold thickness.
Very good. That's a very excellent point that that prevalence that we gave was not based off of clinical examination.
Yes.
Okay, so moving on, I think that even gets trickier. So this slide was showing the various phenotype summaries, but now Dr. Zielinski will show us how going from just general obesity to FPLD can even be trickier.
Absolutely. So this next illustration is helpful just to see the phenotypic spectrum ranging from general obesity in the figure to the left all the way to FPLD. The spectrum begins with the patient on the left who has general obesity to the more rare lipodystrophy syndrome seen all the way to the right. As you move from left to right, you can see the increased sparing of fat in the lower extremities as compared to the patient with general obesity who doesn't have that.
Yeah, and I think really just putting your eye focus to the lower extremity really brings that home.
This slide depicts comorbidities that are associated with lipodystrophy. Classically, patients will have high insulin requirements due to an insulin-resistant state. Thus, more concentrated forms of insulin can be helpful. Hepatic steatosis and severe hypertriglyceridemia can present with eruptive xanthomas and acute pancreatitis. There's also a higher incidence of renal disease in this population, in part due to uncontrolled metabolic risk factors. There's also an increased risk of atherosclerosis and hypertrophic cardiomyopathy from ectopic fat deposition in the heart. Finally, hyperinsulinemia can provoke hyperandrogenism and menstrual irregularity. As we've already discussed, making the diagnosis of FPLD requires a confluence of both physical and clinical features. Key findings will include subcutaneous fat loss in the patient's lower extremities and prominent musculature, together with severe metabolic derangements. Two helpful diagnostic clues include out of proportion metabolic disease to the patient's degree of adiposity and a phenotypic similarity to Cushing syndrome. After a hypercortisol state has been ruled out, lipodystrophy should be considered in these patients.
Then, so if there's no further comments on those last few slides, maybe we'll move into some additional tools to support a diagnosis. And here we have that of skin fold measurements. So skin fold thickness values of the anterior thigh, less than 11 millimeters in adult men and less than 22 millimeters in adult women, as well as calf fold thickness less than 8 millimeters are supportive of a diagnosis. It's important to note that these measurements may be supportive, but not definitive. I suspect skin fold calipers are not routinely found in examination rooms. However, I'm curious if either our panelists have used these calipers to support their diagnosis of lipodystrophy.
For me, we do get them because we do have like a protocol essentially when we're working at patients with lipodystrophy that we do measure skin fold thicknesses, but I don't really, to be honest, like my own practice, I don't really heavily rely on them. I sort of, integrate more the total clinical picture in making the diagnosis. I would hate to like exclude a patient who seems like they have lipodystrophy, but because like their skin fold may be slightly elevated compared to these cutoffs. So I sort of base it more on the general picture. And I also do tend to rely more on DEXA scan, which I think is a little less prone to user error and more kind of objective measurements to help guide the diagnosis.
So they are helpful to us in the sense that, you know, I've been dealing with lipodystrophy for several years and I may be biased. So to eliminate my bias, I need objective measures. And so once we do a thigh skin fold, for which we have some normal values from healthy women, you mentioned less than 22 millimeter in adult women and 11 millimeter in adult men. That gets you to the 10th percentile of the normal. So given the clinical setting, if it is a patient with type 2 diabetes or high triglyceride and hepatic steatosis, and the skin fold thickness is low, the suspicion for lipodystrophy increases.
With that, we have a few more tools that might help us with the diagnosis. Again, leptin levels, as already discussed, play an important but limited and nuanced role in the diagnosis of lipodystrophy. And again, they correlate with the amount of adipose tissue present, so it would be expected to be very low or even undetectable in the generalized forms. But patients with partial forms of lipodystrophy have varied levels. There's no universal cutoff that reliably distinguishes all lipodystrophy patients. However, a leptin level under 4 nanogram per milliliter is often used in clinical trials. Additionally, genetic testing is used to confirm a suspected clinical diagnosis and to clarify the subtype. Just point out that there are targeted panels that sequence a defined set of genes that are associated with lipodystrophy, and they are much more readily available in clinical practice than I think people typically think. And before I get some comments regarding, again, the genetic testing or the leptin level, I just want to point out that our cases, the patient from case 1 did undergo genetic testing, but failed to reveal a monogenic form of lipodystrophy. But based on her very obvious clinical and metabolic parameters, a diagnosis of FPLD type 1 was made, which again is polygenic. And the patient from case 2 was found to have a heterozygous mutation in PPAR gamma at position 130 of a diagnosis of FPLD type 3. So any comments regarding how you utilize leptin levels? Again, we hit that already, or even just integrating genetic testing into your clinical practice.
I think, yeah, leptin levels are tricky. So for generalized lipodystrophy, leptin levels should be low. For partial, they can kind of be anywhere on the spectrum. And some patients, even, with like FPLD1 who can have a higher BMI, those patients can even have like a slightly higher leptin level because they have a lot of intra-abdominal fat accumulation and fat accumulation in other areas of their body. So it's like neither sensitive nor specific, but we always do check it. I'm sure Dr. Garg checks it as well. If it's low, it may potentially help inform a treatment strategy to suggest that maybe the patient would benefit from leptin replacement. But, even that, studies have not really demonstrated that a specific cutoff is helpful in predicting response. Regarding genetic testing, I will say my personal practice is don't order genetic testing until you're very confident that the patient actually has lipodystrophy. It's sort of like, when we work up a patient for Cushing's, you shouldn't order that pituitary MRI until you are sure the patient has Cushing's disease. Because once you see that little nodule in their pituitary gland, what do you do with that if you weren't even sure they had Cushing's to begin with? And are you supposed to send them to the operating room for that? If you are not sure the patient has lipodystrophy, and then you order the test and it's negative, or you order the test and it shows a variant of unknown significance, how do you interpret that now? So it's more helpful, I think, to be confident in your diagnosis clinically first, use the genetics to help to identify the specific cause. But if it's negative, it definitely doesn't rule out lipodystrophy, and it also doesn't rule out familial lipodystrophy. It could just be that this gene was not part of your panel. It hasn't been identified yet. You have a polygenic form of lipodystrophy. There could be many other reasons.
So, in the rather this year, we have reported 2 new genes for familial partial lipodystrophy. One of them is Notch3, and the other one is ACAA2. So, if you did the panel, let us say last year, these genes would not have been sequenced by the commercial labs. So, Lindsay, you're very right that in a person like the case 1, there is always a possibility that she may have other gene mutations which are either not yet discovered or newly discovered. And if we exclude all of them, then we can think about that, well, could it be polygenic inheritance?
Okay, so next up we have another polling question. And this is regarding imaging modality. Which imaging modality is most practical and useful to support a diagnosis of familial partial lipodystrophy? Would you go with a whole body MRI, B, a PET CT, C, a DEXA scan to assess regional fat distribution, or D, a plain radiograph of the abdomen? And 100% already picked C. That's the correct answer, as alluded to. And we have a few slides regarding DEXA.
Great. So body composition analysis via DEXA scan is a suitable, cost-effective alternative to whole body MRIs. A fat mass ratio greater than 1.2 in females is suggestive of FPLD. The ratio is calculated by dividing the percent trunk fat to the percent lower limb fat. This first image to your left demonstrates the normal typical fat distribution in a female without lipodystrophy. You can see the yellow coloring indicating fat tissue with a predominantly gynoid pattern of distribution, indicating proportionally greater fat over the hips and thighs compared to the abdomen and no excess visceral fat. In FPLD, there is a loss of this gynoid pattern of fat distribution. This is the DEXA scan from our patient in case 1, which revealed a trunk to limb fat mass ratio greater than 2. This is the DEXA scan from patient in case 2, which revealed a trunk to limb fat mass ratio of 1.36. So both ratios were suggestive of the FPLD diagnosis.
We have one more polling question, then maybe we'll go back to the imaging modalities. If there's any additional comments from our panelists. So here we have, which complication is a major concern in patients with lipodystrophy? A, autoimmune thyroid disease, B, osteoporosis from decreased mechanical loading, C, liver disease with progression to cirrhosis, or D, obesity-associated cancers. Most overwhelming majority picked C, liver disease with progression to cirrhosis, which is the correct answer that we were looking for. And we're going to present one more slide on the diagnostic imaging regarding hepatic steatosis.
So another form of imaging that should be performed includes a FibroScan to quantify the degree of hepatic steatosis and fibrosis if it's present. This FibroScan is from our second case, which shows diffusely increased echogenicity consistent with hepatic steatosis. The CAP score indicates severe steatosis, but minimal to no fibrosis present.
Any comments from the panelists regarding, again, the use of DEXA? We already sort of commented on that in FibroScan. We do have a few slides getting into treatment, and we want to leave some time for questions. So if there's anything in particular you want to mention about the use of these two tests?
Yeah, I don't want to take up too much time. I'll just say quickly that there is now an FDA-approved treatment for MASLD fibrosis, stage 2 to 3, so not cirrhosis, but sort of earlier stage fibrosis, called resmetirom. And so this is really important to screen for in patients because there is something that can be done if you end up catching kind of the early stages in the progression towards cirrhosis. In addition to resmetirom, GLP medications have also been shown to improve fatty liver, and now Wegovy is actually FDA approved for MASH. And so, two options that you can use in patients, and so something to sort of, screen for in patients with lipodystrophy.
Okay. Then I'm going to present a few slides on pertinent studies and ongoing trials so that we have a little bit more discussion about the treatment of these patients. So to begin, currently leptin replacement with a leptin analog, metreleptin, is only approved for congenital generalized lipodystrophy. This is a 2002 New England Journal of Medicine article. It investigated whether leptin replacement could improve the severe metabolic complications associated with lipodystrophy. The study enrolled 9 female patients with lipodystrophy. They had leptin levels, again, less than 4. They received recombinant human leptin. It was administered twice a day for 4 months at escalating dosages. And what they found at results at 4 months was pretty impressive, with the hemoglobin A1C decreased by about 2%. Triglyceride levels dropped by an average of 60%. Liver volume decreased by an average of 28%, and self-reported daily caloric intake substantially decreased. So again, this was for the congenital generalized form. As of now, metreleptin is not FDA approved for use in partial lipodystrophy. However, studies have shown benefit of leptin analogs in FPLD. In this 2015 article, the authors compared baseline characteristics and metreleptin treatment response in patients with partial lipodystrophy versus generalized lipodystrophy. And in summary, and demonstrated against the waterfall graph to the right, both groups showed significant improvement with metreleptin, but the magnitude differed. So there's 2 take-home points. The first one is that the partial lipodystrophies responded less well compared to generalized forms. And number 2 is that when you're looking at the cohort with just partial lipodystrophy, it was those with worse metabolic derangements at baseline, defined as an A1C over 8 and a triglyceride level over 500, that responded better as compared to those with less severe metabolic findings at baseline. And I just wanted to note that both of our cases are currently enrolled in the open label extension arm of this particular clinical trial, and they're currently receiving daily metreleptin. So any comments from our panelists with their experience with the use of metreleptin in lipodystrophy?
It's also pretty safe for patients with generalized lipodystrophy, although there is a warning about lymphomas, but we have not seen any such case who developed lymphoma during therapy with metreleptin. The other warning is more about hypoglycemia, but that occurs in patients who are taking insulin, and when their energy intake goes down, they may have some hypoglycemia. But overall, it is associated, it is pretty safe also.
There is that box warning also with metreleptin in terms of development of antibodies, neutralizing antibodies to leptin. So this is something we always do counsel patients about, that the medication may suddenly lose its efficacy or even affect your own body's response to endogenous leptin. But it seems like this is very rare, but something that we always sort of have in the back of our minds. And I think currently, by the current FDA regulations, because of this, there's a special REMS certification to prescribe metreleptin, and you need to indicate that the patient does have generalized lipodystrophy in order to prescribe it. You can't use off-label metreleptin for other types of lipodystrophy. Hopefully this is going to change soon, as Dr. Bredefeld mentioned with the MetroPL study. Those results should be coming out in hopefully the fall. And so, if that study is positive, this could really broaden the people, the patients that would be eligible to receive metreleptin, and hopefully, give them access to this really helpful therapy.
Next, we're going to discuss the use of incretin receptor agonists in lipodystrophy. And incretin therapy has been demonstrated to provide significant clinical improvement in patients with lipodystrophy. This study I have here is a recent small observational study of 17 patients, 14 with familial partial lipodystrophy, and they received tirzepatide, which is the dual GLP-1 GIP receptor agonist, for 9 months. And there was a median A1C reduction by about 1% in this study, despite a coinciding reduction in insulin requirements. And the triglycerides also dropped by a median of about 65 points, with some individuals dropping much more, even into the several thousands. So I know I've used incretin therapy in patients with lipodystrophy, one of the things I'll pose to the panelists is how do you reconcile some of the concerns associated with pancreatitis and incretin therapy in patients who have already had potentially recurrent episodes of pancreatitis?
It's a very great question because it's something that I definitely think about in my patients and do counsel them about. My personal practice, this is, there's been some case series like you just showed, and, it seems like it's safe. I think just so that I can sleep at night, I try not to start it in a patient that does have very high triglycerides. I try to get those triglycerides down first, hopefully through lifestyle and fibrates and omega-3 fatty acids and other methods. And then once we get it below hopefully 500 and sort of like a safe range, then that to me is a good time to start a GLP. And GLPs do bring down triglycerides, so like it actually will reduce the risk of pancreatitis potentially over time. I just worry that, if you're starting it at the moment that the person has really high triglycerides, one, could it cause pancreatitis? That's very uncertain. But if they developed pancreatitis at that moment, you would probably have to ascribe it to potentially the GLPs, and then like they wouldn't have access, you wouldn't want to prescribe that therapy for them anymore. So I'm trying to sort of minimize their risk of pancreatitis so we don't have like a confounding issue either, where I wouldn't know if the GLPs played a role in it. So that's my personal practice, but I don't think that there's really guidelines around this yet. So curious what Dr. Garg does.
Cindy, because of the time constraint, I'll let the participants ask us questions in the next 10 minutes, if they have any, and we should answer those questions first.
Yeah, in fact, we do have one question regarding any evidence for the use of ApoC3 agents to treat the severe hypertriglyceridemia. So that is actually our last slide of the evening. So given that was a question, let me address that quickly. And so again, this is the role of ApoC3 inhibitors in severe hypertriglyceridemia. As a reminder, ApoC3 is a small apolipoprotein on triglyceride-rich lipoproteins that slows triglyceride clearance. So ApoC3 inhibitors reduce ApoC3 production in the liver. They lead to lower circulating levels and therein increased triglyceride clearance. Currently, only FDA approved, the ApoC3 inhibitors are only approved for familial chylomicronemia syndrome. But several ApoC3 inhibitors have been studied in patients with severe hypertriglyceridemia and pancreatitis, but without a genetic disorder. Here we have on the left olezarsen, our antisense oligonucleotide, and plozasiran on the right, which is our small interfering RNA. And it showed a remarkable 72% and 80% reduction in fasting triglyceride, respectively, with an 85% and 83% relative risk reduction in acute pancreatitis events. So here we have very robust findings and a promising medication for patients with lipodystrophy who also have severe hypertriglyceridemia and pancreatitis. So hopefully a really helpful therapy as opposed to, our typical low fat, zero fat diet, fibrate type approach, but of course not FDA approved. Oh, yes. And there's another question. I also had this question myself, and I wonder what the panelists would think about this. What is your experience with the use of PPAR gamma agonists, such as pioglitazone, in a patient with FPLD, particularly type 3?
So I can answer that. I think you would think that these are the drugs for FPLD3 patients who have PPAR gamma variants, but there are no placebo-controlled trials with thiazolidinedione so far even in those patients. And one of the concerns that I have is that thiazolidinediones can increase fat mass. And we have seen anecdotally that some patients with partial lipodystrophy develop huge lipomas in non-lipodystrophic regions. So that becomes a concern with thiazolidinediones. I would like to see whether these are special drugs for at least PPAR gamma variant patients. Dr. Goldberg is asking about a study of volanosorsins in patients with partial lipodystrophy with dramatic reduction in triglyceride level. Yes, they are efficacious, but as we know, volanosorsin was associated with reduced platelet count and bleeding, and therefore it was not approved by FDA, even for patients with um, familial chylomicronemia syndrome or for familial partial lipodystrophy.
I believe that's approved in Europe, Dr. Garg.
It is approved, not our FDA. Yes, it is
Not
approved.
our, okay.
Yes. There's a question about, are there any particular symptoms that these patients complain of? I don't think we can generalize it because we have a spectrum of disorders of lipodystrophies with partial lipodystrophies and generalized lipodystrophies and different varieties. Uh, but certainly, for generalized lipodystrophies, patients complain of excessive appetite, and all patients with lipodystrophies are predisposed to acanthosis nigricans and hepatic steatosis, if not diabetes. So the metabolic complications are there in all subtypes of lipodystrophies.
Fourman, I think you're muted.
Yeah, sorry. Also to add to that, I think that's a really great question because we always, as endocrinologists, are focused on the metabolic sequelae of lipodystrophy. But really, these patients often do have a lot of other symptoms and kind of more constitutional symptoms, such as fatigue, a lot of pain, depression, um, muscle weakness, even though they look very muscular, a lot of times they can feel weak, and it might be due to mitochondrial dysfunction, possibly. So I think it's really important to pay attention to sort of a holistic approach because managing those symptoms is really important. And sometimes you may be so excited that, oh, your A1C is looking perfect, we've improved that, but the patient is actually not feeling better because of other symptoms going on. And so it's really important to screen for those and try to address them.
There was a mention earlier about the shelf-like effect in the Coberling lipodystrophy.
Mm-hmm.
Familiar with that, and maybe can provide the audience what that may be, the appearance.
Some patients with FPLD1, which is also Coberling, same thing, lipodystrophy, can have this sort of shelf appearance where essentially they have fat centrally and lack fat peripherally, and there's like a discrete cutoff where suddenly they don't have fat and then suddenly they do, and it kind of gives the appearance of like a shelf where you kind of see this lipoatrophy and all of a sudden normal fat. It's sometimes seen, it's not always seen. If it's present, that can be helpful in sort of confirming that this seems consistent with the diagnosis. But definitely there's many patients that I've seen that don't have that at all. So it's not super sensitive to pick up the diagnosis, I would say.
Thank you.
We have a couple of minutes remaining. Any burning questions from the audience?
Okay, I think we've answered everyone's questions. I want to thank our participants for tuning in to us this evening and our expert panel, Dr. Bredefeld, Dr. Fourman, Dr. Garg, and Dr. Zielinski. You guys did a terrific job. For our participants, I'd like to invite you to join us next month, May 26th. We're doing inflammation, cardiorheumatology, and should be a very interesting last lipid panel of the year. For anyone else that has cases or thoughts and wants to do a program, please reach out to Chloe and myself. And again, thank you to an expert lipodystrophy panel. You guys have a great night. Appreciate it.
Thank you for having
Thank you.
us.